Okay, management of cornea complications after refractive surgery. I think this takes more than 20 minutes, perhaps the whole weekend. Some ouzo. I'm going to try and do my best within this next 20 minutes, although we have some speakers coming up that will elaborate more on some of the specific complications I'll try to cover. I do have financial disclosures with Alcan, Avidro, Allergan, Ioptics, Keramid, Zeiss, ISP Surgical. I do not have any financial interests in complications. So refractive surgery, today we can separate between cornea-based surgery with all the procedures we do on the cornea, PRK, Lasik, SMILE, RK, inlays, intracorneal ring segments will be some of them, and then lens-based procedures such as phakic IOLs, premature cataract surgery, et cetera, et cetera. I try to separate these, and I'll briefly go over them. In intraop complications, obviously problems with the Lasik flap have been some of the most popular ones to be reported and studied, mainly when a microkeratome, mechanical microkeratome is used. Most of those have been subsided, not all of them, with the use of femtosecond lasers. SMILE is a new cornea refractive procedure and appears to be effective and safe, although it has shown to have its own intrinsic problems. Decentration as far as the ablation, perforation, early post-op complications, DLK, CTK, epithelial ingrowth, street infectious keratitis, the list goes on and on and on. And transient dry eye and late post-op such as decenter ablations, residual refractive error, ectasia, haze, fluctuation with older patients that were treated with RK, inlay melt, and intracorneal ring segment melts. So there's a lot of material here. I'm going to try and briefly fly through them. As far as the Lasik flap, we do hold for the fall ESCRS a very nice course over the last 15 years on Lasik complications, and most of this course, it's a 2-hour course headed by Jerome Vrigem, is dedicated on microkeratome-related flaps now, and I personally have been using the femto since 2006. We're the first femto in Greece. They're almost very rare to see. You see on the top here a picture of a complete flap, a little bit of a problem with the keratome. My advice on this today would be to perform the Lasik procedure and suture the flap in place to be 100% sure that you'll find it the next morning. Epithelial abrasion was also a mechanical microkeratome-related complication in patients who had mainly mapped out fingerprint dystrophy. Buttonholes, again, a problem with mainly mechanical microkeratomes. Vertical gas breakthrough is a unique femtosecond-related complication you can see here, trying to do a flap in an older Lasik patient, one of the first Lasik procedures ever performed in the world and here in Greece. And you can see that the old Lasik flap from the keratome is allowing vertical gas breakthrough, a new type of complication that we see with femtosecond laser lamellar surgery, and it's invited by mainly cornea scars. So our attention to evaluating these patients pre-op is very important on the slit lamp. Most of these cases now would be in contact lens users that would have a sterile, old sterile infiltrate that will create a scar. And of course, loss of suction, et cetera, et cetera. This is a significant complication with SMILE that I had seen here. Flew to Athens to be treated. This unfortunate young lady had 3 sequential passes on the Visumax that lost suction, and then the surgeon decided to convert the SMILE procedure to a relix procedure, cut a Lasik flap, and manually remove the lenticule. And what happened was that she was significantly overcorrected. She came in with this very, very, very thin cornea. She was treated for myopia, but you can see that she is high myope now. Not really ectatic if you look at the thickness maps here and the epithelial profile. And what we decided to do on this young lady is treat her with a combination of topography-guided normalization and cross-linking. And she did improve dramatically. She received a second PRK to treat some residual refractive error as seen here, and now she's improved to uncorrected 20/40, best corrected 2025, not perfect, but certainly better than a transplant, which was her only option at that point since she's contact lens intolerant. Jumping into DLK, I've yet to see a DLK case in over 10 years now, because I think we've become more careful in our OR environment and the instruments that we use, and the using single-use instruments, and or careful how we autoclave our instruments. Some key points are noted here. Obviously, the pathogenesis is multifactorial, and be aware that if it does not go away after several weeks, you have to scan the eye, preferably with an OCT, to avoid that eye having high pressures, percolation of fluid within the flap. This is a patient I saw just a few weeks ago here in Athens, and falsely measuring low pressures on the tip of the cornea with applanation. Meanwhile, this patient, if it goes on for several months, can lose their optic nerve from silent glaucoma. Now, this is another case with DLK that was lifted, developed significant epithelial ingrowth, and CTK, central toxic keratopathy, which I've rarely seen in LASIK. I've seen it mainly in PRK. It's a very rare complication. Both eyes, a humongous hyperopic shift. This was again treated, I think, in Cyprus, and so it's here in Athens. We were able, just with conservative therapy, use preservative-free steroids, topical cyclosporin A, and tears, and just waited out to be able to improve. You can see here how dramatically the flattening effect improved over a year and a half to reasonable visual acuity of +2.5, -2 at 30 degrees. 2020, again, in some of these cases, doing less is more, and always be aware of iatrogenic toxicity on these eyes. And we heard previously how some medications can have deleterious effect on the cornea. This is a case, some of the worst that I've seen was striae and epithelial ingrowth. This young gentleman had his girlfriend help him with a toothpick, pick his Lasik flap whenever he felt he wasn't seeing well, and try and correct his epithelial ingrowth. I advise my patients not to do this at home, obviously. And the way we treated this, and all these videos are available on the YouTube channel of our center. It's LaserVision Eye Center in Athens on YouTube. You can see how dramatic the epithelial ingrowth is in here, how bad the refractive error is. We lifted the flap. The caveat here is that some of the epithelial strip was behind the flap. So when you lift the flap and you remove the epithelial ingrowth, you want to pay close attention to the backside of the flap. You can see the strip of epithelium removed here. This is an instrument that's heating up the actual flap in order to remove the wrinkles at 55 degrees, resuture the flap in place. You can see the dramatic topographic difference. So many ways to skin a cat, many ways to approach this. This is my favorite. Now, central toxic keratopathy, again, now on a PRK case, and this is a devastating complication. We yet do not know the etiology of this. Some people think it's an old viral infestation of the cornea that's exacerbated by an excimer laser ablation. It could be medical treatment related, the antibiotic or the steroid drops we're using, but you see significant inflammation throughout the whole cornea, significant melt of the cornea, and very little to do. You can see this patient started with significant myopia, was treated with PRK, and developed a significant CTK that was ended up with her having a +10 refractive error early on, but again with conservative treatment, preservative-free steroids, and caring for the anterior cornea surface, was able to give her reasonable vision without necessitating cornea transplant. Something to be aware of for those of us who do surface ablation and patients that may have pain the first night is that some colleagues do give diluted anesthetic drops to patients. Some patients are smart enough to buy them from the pharmacy or pick them up from your examining room when you're not there or your staff is not there. And this is a devastating complication we encountered here in Greece of a patient who was self-medicating with topical anesthetic. You can see the devastating toxicity in the cornea. I had not seen this since I saw patients in urban New York City that were crack users, and the cocaine from crack went into their eyes and created this significant cornea melt hypoxia. You can see the ectropium iridis behind and recalcitrant glaucoma. So again, be aware that a simple procedure and an extremely effective procedure like PRK can turn into a devastating procedure if patients self-medicate with topical anesthetics. We did a graft, and the balance with this patient is very rough. Now, of course, there's some mild complications such as transient dry eye. We all know incisional procedures are more related to dry eye. Lasik is probably the most insider of dry eye. We felt SMILE would be very little contributing into dry eye. In our comparison study published in the Journal of Cornea this month, looking at 2 years, one eye Lasik, one eye SMILE, you see that the procedures are more similar than dissimilar in dry eye, and it peaks between month 3 and 6. And we also have a publication on using topical cyclosporin to weather this dry eye, transient dry eye that we see with Lasik. Obviously, picking patients who you do not expect to have significant dry eye for Lasik or SMILE is important. In our practice here in Greece, it's mainly female patients that will experience most of the dry eye symptoms, and consider that the surface ablation and or phakic IOL may be better alternatives for some of these patients that do show signs of significant dry eye as a predisposition. And again, this is the publication on using topical cyclosporin with dramatic better effects on treating dry eye. Of course, what we fear the most is to implant a bacterium or a fungus in the cornea in cornea-based refractive surgery. And this is a progressive ulcer, as you can see here, starting at week 1, 4 weeks recalcitrant to treatment. And when you see a histology section of the cornea of a patient who's had refractive surgery, you know things did not go well. What we saw here was an aggressive fungus that was inadvertently contaminated within the flap. And you know the fungus is very aggressive when the hyphae have vertical orientation in the stroma. That's a sign of significant aggressiveness by the virus, and the therapeutic PK there was good enough to treat it. This is a young physician that spent her time between London and Greece and had a infectious keratitis after Lasik. We saw her here on just Tobrex drops, and we employed, besides fortified antibiotics, vancomycin and cefazolin, a topography modified high-intensity CXL. We designed the XY nebulous area to be treated and treated with the KXL2 device to spot focus 20 milliwatts, 10 joules of total energy, and have this dramatic improvement within 1 day of the nebulous infiltrate, of course, along with topical antibiotics, vancomycin and cefalozin. So just a thing to consider. These are the reported suspects for infectious keratitis after refractive surgery, thus making necessary the use of quinolones, probably 4th generation quinolones, as one of the key prophylaxes for these patients. Ectasia, you may be familiar that it has been a favorite item for our group here in Greece. We've reported extensively on the treatment of ectasia. Of course, the best treatment is prognosis and choosing patients carefully so not to have ectasia. It's difficult talking about ectasia after corneal refractive surgery in a country where we feel 1 out of 20 Greeks has keratoconus. It's different than probably an Anglo-Saxon country where the incidence may be 1 in 2,000. So there are several criteria. Rule of thumb is do not treat with Lasik or SMILE corneas that are suspicious. Sine fluke imaging has become a universal screening method, but we feel that cornea epithelial is more sensitive. For instance, this patient looks normal on sine fluke imaging, but you can see the epithelium here tells a different story. This is a subtle keratoconic patient that we would not treat with Lasik if laser correction was to be done. This is a medical legal case I had to see in my New York City office, labeled by very esteemed colleagues in the US as post-Lasik ectasia. This carries a very high medical legal value in the US. If we look at the sine fluke imaging, we see that the cornea thickness does not correspond to the steepest of the cornea nor the backside of the cornea. And this is nothing than a decentered ablation. So realizing and knowing the cornea diagnostics well is important. Again, this is a similar case, a slightly eccentric ablation in the old times of broad beam lasers that looks like ectasia, but the cornea thickness map is normal, and this will be treated with a topo-guided fix and no cross-linking. But when real ectasia comes in, we know that cornea cross-linking is the way to go. We've published extensively on using the Athens protocol, which is a combination of topography-guided laser normalization and higher fluence cross-linking. These are some of the first reports in the literature. We reported over 1,000 cases now in over 25 publications, along with other colleagues as well, on treating post-LASIK ectasia. This is one of the star cases, a young helicopter pilot in New York that developed ectasia after LASIK, and we're able to bring him down to 2010 post-op, have him pursuing career as an aviation pilot after that. And the principle here is to do a topo-guided normalization here, the PTK that accounts for the epithelial removal, mitomycin C, and higher fluence CXL, as seen here. And there's question whether CXL should be used as a prophylactic agent in high-risk LASIK or high-risk PRK. The jury is still out. We certainly have advocated in younger patients with high levels of myopia to be corrected, and hyperopic patients, but I would certainly not endorse using LASIK extra for firm-fused keratoconus. Those eyes should be treated only with surface ablation or a phakic IOL instead of that. RK, we don't see that many patients anymore, but there's many of them out there, both in Europe and the US, and this would be a decentered ablation. It's not really an ablation, it's a functional optical zone from a decentered RK. And of course, we're all familiar with humongous hyperopic shift these eyes have years to come. So treating these topography guided may be able to help. You can see here before and after result that's quite rewarding, along with CXL. And again, we've reported extensively in the past using both topography guided platforms and waveform guided platforms, along with other esteemed colleagues, on treating these cornea irregularities that may be result from decentered or irregular ablations. But be aware that a patient that you've treated a -8, and I saw a lady in the office last week, that 12 years later, she's 45 years old now, is -2, does not necessarily mean that your LASIK has regressed. If you have the data, we had axial length measurements, cornea topographies before and now, pointed to the fact that she's just developing a nuclear sclerosis cataract. And you have to address that because she may have room to enhance that -2, but the nuclear sclerosis will continue and she'll come back for more and more. And addressing the pathology and how it will be treated is very important. We are now well aware of post-PRK haze and how to protect with that. We have a lot of UV exposure in Greece and in general in Southern Europe and the Mediterranean basin. There's many ways to treat this, but inadvertently sometimes you have to deal with that. We've anecdotally seen late haze 2 years after PRK combined with cross-linking in pediatric patients, and we're presenting that in this meeting as well. So something to keep in mind. It may be an intrinsic problem for pediatric patients, and you can get cornea melts even with Intacs. This is a patient we treated who had Intacs for keratoconus for 14 years. They stayed silent and all of a sudden developed a melt infection. We had to remove the segment from inferiorly and create a patch graft from cross-linked cornea, suture in place. Patient did fine. A lot of cornea acrobatics to avoid a penetrating graft, but a real complication which we had addressed in the past in the literature. These are papers on post-intracorneal ring segment complications and post-phakic IOL complications. This is a very rare case for me, an Agorov ex-Soviet Union lens that was placed for very high myopia and RK that caused, besides cataract, cornea decompensation. It was treated with removal of the phakic IOL, cataract surgery, and a DISEC graft successfully. So again, everything has complications, as do multifocal or trifocal lenses that are intolerant for patients. So careful selection of patients and addressing their needs may avoid you having to remove this lens out. And I'll close with some inlay complications. I'm not a fan of inlays. I'm not a fan of foreign material on the cornea. These are some cases that I did back in 2010. Significant cornea melt, significant cornea irregularity right in the visual axis. So very careful in using inlays for refractive surgery. So in summary, I try to brush through, although the subject is very huge, on cornea and lens-based refractive surgery complications, although cornea and lens-based refractive surgery was never safer, never more effective, and I look forward to hearing the speakers describe more of these, and I get the opportunity to learn more as well. Thank you very much for your attention.